Hello, and welcome to the From Truth to Action podcast. I'm Jay Hurtubise, Director of Community Standards at Framingham State.
And I'm Ben Trappenick, Director of New Student and Family Programs, also at Framingham State. And we're honored to be bringing you this limited series, exploring the ways that biases and systemic racism impact our communities. Each episode will be looking at personal stories and real events with our guests in order to frame our discussion and lead us to anti-racist action.
As always, we want to provide our audience with a trigger warning due to the deeply sensitive and often traumatic nature of racism, inequity, and injustice. We also encourage you to practice effective self-care, however that looks for you. And we remind you about your on-campus support resources, which may include counseling centers, campus ministries, and also campus contacts for multicultural affairs, diversity, or inclusive excellence.
I've been thinking about coronavirus and how even by protesting to save our own lives, that is putting ourselves at risk, whether from the police or from the virus. It's just really hard. Even if after this pandemic is over, there's a vaccine, if Black people are still dying, going back to normal isn't good enough. I think a lot of people realize that we've needed change since before this, and going back to a world where Black people are still dying disproportionately, it's not enough. Jordan, 25. My experience with racism in healthcare began as I was looking for a job after my residency ended. I asked for a recommendation from the lead doctor I had worked with for 3 years and got a yes. Once I got the job, which was a per diem temporary position, the woman who hired me let me know that my former lead may not be an ideal reference. The lead doctor had said, well, she is not a go-getter. The woman hiring had asked, what do you mean? Is she smart? Does she know what she's doing? Does she work hard? The lead doctor said yes, and I was hired, but another Black doctor from my residency told me that he had applied for a similar per diem job with our former lead as the supervisor. Even though they had worked together for 3 years, the lead doctor asked my friend to interview for the position. At the same time, that lead doctor went out of their way to create a new full-time position in the same clinic for a white male student from our residency. Black doctors already exist at the margins of our field. In fact, in 2018, only 5% of MDs were Black, and today, only 7% of medical school students are Black. Maya, 38.
Hello, and welcome to the From Truth to Action podcast. My name is Jay Hurtubise. I'm the Director of Community Standards here at Framingham State University, and I'm joined as always by my co-host, Ben.
How you doing, Jay and Ilene? Thanks for having us being here today. And Ben Trappenick, I'm the Director of New Student and Family Programs here at Framingham State. And welcome to our third episode in the series. Now we'd like to introduce our guest for today. Today's topic is going to be focusing on healthcare. We're going to continue our discussion on what we've seen and people have seen about racism in certain systems. And today's is about healthcare, and we're very fortunate to have our Director of Health Services here at Framingham State, Ilene Hofrenning. Ilene, thank you for being here today.
Glad to be here, Ben. Thanks for inviting me.
Yeah. Can you just give us an introduction? Can you just mind taking time and introducing yourself and tell us your background and experiences over the years?
Sure. I'd be happy to. I've been a nurse practitioner for about 35 years, and I've worked in, a variety of different types of settings. Some that are relevant to our conversation today. One of the first places I worked was a few years after I got out of school. Actually, this is before I was a nurse practitioner. I was a nurse. I worked in Norway at a couple different hospitals in Norway. And I went to Norway because I'm from North Dakota and everybody there is Norwegian. And my heritage is 100% Norwegian, and I always wanted to go there. So I went and worked there. And as you probably know, Norway has universal health care. Everybody has access to healthcare, no matter if you're employed, unemployed, young, old, rich, poor, whatever. Everybody has healthcare. It's absolutely considered a right. Norwegians are very proud of their healthcare system, and they, are horrified with what goes on in the United States. This was a number of years ago that I worked there, but it's still the same. that how can the richest country in the world not provide healthcare for all its citizens? I sort of felt like I was asked to defend that system, and there's no defense. There's no defense of that system. That we see healthcare as a privilege. You have to earn it. You have to be employed. Otherwise, you're put in, poor systems to get your health care. And, that was quite eye-opening to me, to really be in a system where healthcare was, available to everybody, and it was seen as everybody's right. When I came back, I became a nurse practitioner, and then I worked for a number of years at a community health center in Worcester. This was a healthcare system that saw people that were pretty much lower socioeconomic status. A number of people were in poverty, many immigrants, people of color, people with unstable housing, many factors that affected their health. And of course, people who are Black, people of color tend to have higher diabetes, hypertension, heart disease, obesity, and we saw all that, and also saw, how many of the factors of their lives contributed to poor health. I mean, now we call it the social determinants of health. I mean, that phrase wasn't there then, but you could, provide the best medications, set up the best tests and diagnostic tests and treatments for people. But if they didn't have money to buy medication, or didn't have transportation, or didn't understand the importance of getting a certain test or managing their health, whatever you had didn't help them. That you had to really look at their whole lives and address a lot of those issues that were affecting their health. And I think, we're starting to realize that now, that, people are really looking at social determinants of health, and we have to figure out what, how to address those to impact people's health. So I was there for like 17 years, and then the opportunity came at Framingham State. So I came here, job that's sort of half administration, half clinical. So it's a nice combination of things. And here there were things that made work for me much easier. One was that we didn't bill students for any care. Students come here for care, and we don't bill an insurance company. We just provide the care that they need, and don't think how we have to justify that to an insurance company, or think, how do we have to document this so the insurance company will pay the maximum amount of money? I mean, that's what a lot of healthcare ends up being. We could just do what we need to do for students. If they needed to be referred to a specialist, in Massachusetts, we're so lucky because students, even before the ACA and the Massachusetts healthcare plan, students had to have health insurance. So every student had health insurance. We could refer them to an orthopedist, an allergist, any kind of specialist, and know that they had health insurance to pay for it. I would go to conferences, like national conferences with other college health directors, and they would tell me that 90% of their students did not have health insurance. So their care totally depended on what the student could afford to pay for. They couldn't send them to specialists. Even medications, they would have to choose the very cheapest medications, because the students didn't have the money to pay for it. So it was very fortunate in that way, that we could just provide care that students need without having to worry about, can they pay for it or not. I mean, that's not 100% true, because even though students are supposed to have health insurance, not all of ours do, or there can be roadblocks, but it's much less. I'm sure that you all have noticed that our student population has changed. I've been here now for 17 years, and our student population has changed, where we are getting more students that are first generation, that are coming from inner city Boston that are students of color, and seeing how these social determinants of health are affecting our students, if they come from unstable housing, if, they have drug addiction or abuse in their families that they're concerned about and worried about, the anxiety that's there with that. So we are seeing more of that now at Framingham State, and having to address that and work more closely with the counseling center and others to address that. And then my other experience is that I sort of missed the population that I was working with in Worcester. And there's a program in the Metro West area called the Metro West Free Medical Program, where providers volunteer their time to provide medical care to people that do not have health insurance. And it started in a temple in Sudbury, where they were providing general medical care. And I found out about it and became involved in 2008. And we decided to open in Framingham the care for women's health and vision care. So, we've been providing care for primarily immigrants, undocumented immigrants that have no place to go, really no place to go for healthcare, and have no idea if they qualify for any type of benefit. And also are really afraid of going to any kind of institution because if they're undocumented, they're worried that they might be turned in and then deported. So it's a high risk population. Most of them non-English speaking. Most of them have not had any type of primary care for a number of years. That's a program that I've been working with, and we just reopened. We had telehealth for a year and a half over COVID, and we just reopened to see patients in person about a month ago. So that's sort of my experience with healthcare and with health inequity as well.
Oh, yeah. Thank you so much for sharing all of that.
Sure.
Yeah, and as our audience can probably already tell from our intro, we had two different stories, regarding, issues of inequity in healthcare. And those stories are also quite a bit different from the stories that you were just telling about your personal experience. And so this is sort of mirrors what Ben and I found in our preliminary research for this episode, is that we were overwhelmed about the directions that we could go in terms of dealing with inequity in healthcare. And so we ended up deciding that, the route that we really want to go is focusing on your experience and focusing on what you were just talking about with community health. Can you tell our audience a little bit more about what is community health as opposed to what they might imagine for corporate healthcare?
Right. So community health care is looking at sort of the patient in context of their community. So it's not just looking at the patient and, what are their diagnoses or, health parameters, but it's looking at the community that they come from and how that contributes or detracts from their health. So, it's looking at things like the housing stability, food insecurity, environmental issues, where they live safe. What about lead paint, asbestos, living in an older building, overcrowding, also looking at racism and how that plays a part. Looking at drug use and abuse, domestic violence, what kind of support is in the community? Is there religious support? Is there, family support? Also looking at employment. What kind of health effects are in, from employment? Is someone exposed or at higher risk because of their employment? And transportation and, childcare and all those things.
That's a long list.
Yeah. And Ilene, can you just talk a little bit, Jay, sorry to interrupt. Ilene, can you talk a little bit about some of those determinants and how they lead to, like, housing? How does housing instability lead to greater risk of health issues or food? I mean, food insecurity is probably self-explanatory, but describe about some of those, how those factor into people's health issues potentially.
Right. Well, I mean, just think about it. If you didn't know where you were going to be staying for the next 2 weeks, and that's kind of how we described it here. The anxiety that would cause, and it relates also to food insecurity, because if you don't have a stable household, how do you prepare food? How do you get good sleep if you, are moving from place to place? How do you, like if you've got children, they end up having to go to different schools and switching schools. And that's, also anxiety provoking. Having a stable household is one of the really important things for, decreasing anxiety and, maintaining health. It's really important.
Okay. And, you talk a lot, you mentioned a lot about the mental health as well. Mm-hmm. and how that affects things. And that is part of healthcare. Mm-hmm. A lot of people don't necessarily think that, initially they think the physical health, but mental health is a big issue. And I think we're finding, at least over the research, more is coming out now about just how being a person of color already is an anxiety inducing mm-hmm. experience on a daily basis mm-hmm. because of, any number of racist or being excluded or whatever the case may be. Mm-hmm. All the life of being a person of color in this country is also a daily anxiety provoking experience. Was that a safe right. assumption? Yeah.
Yes. And I would say that, I have learned a lot in the last few years, especially at Framingham State, now that we have really decided that we are an anti-racist institution, and we've had a lot of the anti-racist conversations and presentations and all that. That I think I was sort of looking at it through the lens of socioeconomic status, mm-hmm. And realizing, yes, people of color are in the lower socioeconomic status, in higher proportions. But that's just kind of the way it is, and wasn't really thinking about how racism plays into that. Yeah. And now I really understand how racism and health inequities really are intersectional, and affect each other. But yeah, so racial trauma. I mean, there's been a lot of research and writing lately about racial trauma and, the hypervigilance. And I really didn't understand this until I heard it from students, that, like leaving their house every day, kind of like feeling like I have to be careful. I have to watch out. I have to be careful when I go into Walgreens because someone's going to be watching me because they're going to think that I'm going to steal something. I have to be prepared for microaggressions. And do I, confront somebody on that, or do I just let it slide? And to have that day after day, is mentally and physically harming, because if you're hyper vigilant like that, you have increased secretion of adrenaline and, other sort of stress hormones that affect health. And, that's a good reason why, people of color have, higher incidence of hypertension, possibly asthma, heart disease, and also shorter lifespans. So it all plays into that.
So the mental health feeds into the physical health.
Absolutely.
Absolutely. Right. I mean, that's kind of the point there. It's like the stress of it all, mm-hmm. Affects how and you just described some perfect hypertension, heart disease, things like that. So I'm glad that you shared that. So thank you. And mm-hmm. I do want to say thank you for sharing that you like Jay and I have spent a lot of time over the past 2.5 years or so, just soaking it all in and really learning
Right.
Yeah.
well. So
Yeah.
not everybody's willing to share that they've experienced that too. So Jay, go ahead.
Yeah, it just something Ilene was just talking about made me think of actually connecting to our previous episode. You know, you were talking about sort of the biophysical responses to strains and stressors, and it made me think of our conversation that we had with Joe about resilience, right? And like how much like hard working, right, like certain students have to be, and like how there's this perception that some students, particularly students of color, just like they weren't working hard enough to get out of something. But the reality was that they're actually working twice as hard, if not more, and it was the fact that they're doing that from an early age, right? That the social construct is putting them in a believed or perceived deficit, right? When that wasn't there, forcing them to work even harder. So like you were talking about shortened lifespans of things, it's like, well, I mean, they're experiencing this level of stressor very early, causing issues down the line potentially.
Right. And then there's also the issue of healthcare access, so they might not be getting healthcare until, they've had hypertension for a number of years, or diabetes, or, cardiac issues, whereas, things could have been prevented if they would have gotten treatment before that.
And let me follow up with some of that, because you said some things when you were doing your introduction that really brought, I wanted to put it out there as well. Like, a lot of times people feel like that when you have hypertension, when you have diabetes, those are personal choices that you've made that have led to that, right? But in a lot of the determinants that you were just describing, okay, how does that feed into, okay, it may be a personal choice to go to a fast food restaurant for dinner, which we all know is not the healthiest way to go. But if you can get 5 for $5, or whatever you want to call it, and have a full meal and be full, versus going to a grocery store that may not even exist in your neighborhood, that is accessible if you don't have transportation, and your income is less, you're working on a very fixed income. That's not really a choice. Am I
right? No, not at all. And fresh fruits and vegetables are not cheap. I mean, right. I remember when I was working in Worcester, mothers would feed their kids hot dogs a lot. They're cheap, and kids love them. And, it's not the healthiest food, but, that was a staple of many households. I think some, I know that, like, for instance, the SNAP food stamps, you can now use at farmers markets, so that's an attempt and a step in the right direction. But, yes, you're absolutely right. And the other thing about grocery stores, I mean, if you, look at Boston, there's a lot of neighborhoods where there's only convenience stores, that there is not a grocery store close by, so if you have to travel by bus, several buses to get to a grocery store and drag your groceries home, and you've got several kids, I mean, you're not going to do that. You're going to go down to the convenience store and get what you can get.
It's not a case of, well, it's just easier it's a case of necessity, right? I mean,
right.
It's not a case of it's not as simple. It's not as simple as just saying, well, just eat better. Like, you
right.
Make better choices. Like, type 2 diabetes is, I think a lot of people would say, okay, it's preventable. It's not, you're not born with, and it's not something that happens, when you're pregnant, they keep an eye on it for, that's 3, correct?
Yes.
But type 2 is definitely what you're putting into your body. But that doesn't necessarily mean that you have the choice all the time to go get stuff that can be put into your body. And I think that it's not as simple as it's a personal choice.
Right.
Making bad choices about what you're eating. it's not that simple. And a lot of people will not admit to their healthcare providers, like, well, I don't have a grocery store that I can get to.
Right.
Basis tracking, 2 or 3 kids.
Right. Or sadly, healthcare providers won't ask and just say, well, here's the diet you should follow, and not check in and say, are you able to get these foods? Are these foods something that you would and your family would eat? You can't, because you can't expect someone to eat different food than the rest of their family either. I mean, someone who's busy to have to prepare 2 different meals, so there's all those issues.
Right. Thank you for clarifying that. That was a point I think I wanted to bring up too, which,
and the other thing, with, type 2 diabetes and obesity, is, we always encourage exercise, but, some people do not live in an area where it's even safe to exercise. Yeah. There might not be any parks around, there might be, maybe gang violence in their neighborhood. They don't want their children to go out. They might much rather have their children, playing inside on the computer than going outside and maybe in danger. I think when I was in Worcester, we had an interesting program where, we decided that we wanted to provide exercise for our patients, not only for diabetes and, obesity, but also for depression and anxiety, and got a grant for our patients to go to the Y and meet with a personal trainer and be able to go to the Y. And there was some thought like, oh, our patients aren't going to do that. And it turned out that they did, and they loved it. They would go and get on the exercise bike or take a class and, felt much better, lost weight, and, did really well. Not only did we, provide access to the Y, but also transportation and childcare, because those are other barriers for families.
Yeah.
Yeah, I gotta say, a huge takeaway for me from this part of the conversation has just been that, we imagined access being about access to healthcare, right?
Yeah,
you think about 2 healthcare providers, but this is just sort of eye-opening in that it's about access in terms of health. It's about access to so many things.
Right. That's true, that we have to think about health sort of in a different way. And I think especially in the United States, the way that we do healthcare, where it's, fee for service kind of thing. So you get healthcare if you get this visit or you get this test or, this diagnosis or this surgery, but it's not really looking at the whole entire picture, which is too bad.
Yeah. And it brings, all the stuff you just described, it just brings me to the, a really great question is, and I think we talked a little bit about it, but like the importance of community health systems. Mm-hmm. And, community health centers, one I'm familiar with because I live in Boston is Whittier Health. You see a lot of advertisements for it. It's right in the community. So how does that kind of serve the need of some of the stuff that you were just describing, and how does it differ a little bit? I think you answered this a little bit earlier, but if you could kind of compare and contrast a little bit, how community health centers differ in services provided or just philosophies, if you will, mm-hmm. to larger medical centers that, or even health centers that are in more affluent neighborhoods, if you will. Mm-hmm. Mm-hmm.
Massachusetts has a really strong system of community health centers. I mean, I'm not sure how many there are, but there's quite a few. And it's sort of looking, like I mentioned, at the person in the community. At the community health center that I worked at, most of us were family healthcare providers, and so we provided care to the whole family. So we had an idea of the family structure, what the stressors were on the family, what was going on with one person might affect somebody else in the family. So that was really helpful to be able to address what their needs were, and also, trying to provide culturally competent care. If people are immigrants or, from, like a Vietnamese community or Brazilian community or, Black community, trying to understand sort of the cultural underpinnings and what some of their health beliefs might be that might be preventing them from accepting some of the healthcare that you have to offer, providing healthcare in their language, or, making sure that you have good interpreters, to help with that. And then also, having a large social service kind of component, in terms of both mental health, but also concerning, figuring out transportation for people, providing certain health classes, like nutrition, or, doing group visits for diabetes. So you can have sort of a support group, as you're dealing with your diabetes, and sort of supporting and helping each other and giving each other tips and that kind of thing.
A lot of those community health centers and services you described dependent upon the patient having health insurance?
Well, what, all health centers do, and what actually we do with the free medical program I work with, is we try to set people up and have them apply for anything that's available for them. The lowest of the low is a certain kind of Medicaid General that you can get that will pay for emergency care and maybe some other things as well. The ACA, the Affordable Care Act, really helped because they mandated that insurances pay for certain preventative care, like pap smears and mammograms and STI testing and cholesterol screening and that kind of thing. So that helped. But at community health centers, they'll take everybody, whether you have insurance or not, and assist you in getting any kind of insurance that you can. But still, if you don't have insurance, there'll be some sort of self-pay option, payment plan, whatever. Now, as opposed to specialists, and I run into this, referring students to specialists, and I'll call it like an orthopedic office. And the first question they ask before they want to know the patient's name or, what I'm referring them for is, what kind of insurance do they have? And if they have the wrong kind of insurance, well, sorry, we're not going any further. Or, what's happened with some students who've had insurance that the office maybe doesn't have a contract with. They want the patients to pay, or the students to pay upfront, and then get reimbursed by the insurance company, which most students can't do. We've had students that have foregone treatment because of that, because they didn't have the $400 or $500 that they had to pay.
Yeah. Okay. Thanks, Jay. Did you have a question?
I was just thinking about. We were just discussing earlier, the initial story where they were talking about coronavirus, right? The vaccine coming out and there being still an issue. Like, if after all this, because we're in the midst of the pandemic still, after all this, if Black people were still dying, it's just, there hasn't been enough that's been done. And that, it sort of reminds me of this idea of trust, right? And I'm wondering about, how, is there a concern in terms of the trust or maybe the distrust of, healthcare centers or healthcare providers, and how that plays into providing healthcare to folks?
I definitely think that it does. I think especially with older people, everybody knows about the Tuskegee syphilis study where Black prisoners were, purposely infected with syphilis to see, and not treated, just to see the course of the disease. There's been history.
And they didn't know that was happening either.
No, yeah, right.
It's not like they consented to it. So you took prisoners, and because they were people of color and prisoners, double whammy.
Yeah.
Then the people just felt like, well, we can just do whatever we want with them. So
yes.
And I have to know, Ilene, you said everybody knows, but I'd be willing to bet that much of our audience probably doesn't know.
Yeah.
So we'll definitely link something in the end of our video that can educate people on what that was.
And there's also history of forced sterilization. that I think still resonates for some people. So I think that, so now that we have the coronavirus vaccine, there's people that are wondering, is this experimental? Are people experimenting on me? I don't know if I trust this or not. And I think that is especially prevalent in minority communities. Although I just heard recently that someone was saying they think that's been overplayed a little bit, that there was a study and they looked at, white people and I think Black people or minorities anyway, and compared, or asked, are you willing to get the vaccine? And 70% of both groups said they wanted the vaccine. And that, maybe access really is just as important as hesitancy. Because we know that, when the vaccine first came out, affluent people were going all over the place, traveling hours to get the vaccine, and, people who are not affluent cannot do that and, didn't do that. And need, so we need to, and I think, somewhat happening is the vaccine is going to neighborhoods and to places where there's low uptake of the vaccine and offering it to people, who will take it.
And there's other factors too. There's, we talk about the historical things. I'm so glad you brought up, the Tuskegee and forced sterilizations. And of course there's Henrietta Lacks.
Oh, right. Yeah.
And how she was a woman in Johns Hopkins. She went there and she ended up getting diagnosed with cervical cancer.
Yeah.
And they took her cells as a blood test or whatever and realized her cells were mutating or they were just evolving in a way that they had not seen before. And they ended up using her cells without her knowledge and profiting for them in a variety of different ways that had a huge benefit to the medical community, but never, there's a whole ethical discussion about that. So there's just another example. And then on another side of it too, is just that the medical field doesn't always treat, and when it comes down to racism and, believing and symptoms are, and what they're saying, their threshold for pain, and, or making some assumptions about why they have their pain and what they've been doing to themselves, or to get to the point of where they are, which already biases. And people are biased. They are. It's just natural, right? So you've got the distrust of healthcare providers as well, whether it's with coronavirus or not. That leads to distrust. Like I've had this. I go to a doctor and they don't believe me when I'm telling them. They're like, I'm not seeking, OxyContin because or whatever the case may be. I'm in pain. Well, you're not as in pain as much as you think you are. I'm like, well, so you read about it, and again,
right.
And I've not seen it myself. I've been reading about it, so maybe I've just been reading in my bias as well. But that's not an uncommon thing either, correct?
Right. There have been studies that have shown that, that if, a minority person or a white person goes in with, like, say, chest pain, there's different levels of care that's given, that the white person might get all the cardiac workup and, that, the Black person might not get that or doesn't get that, and so it's looking at why does that happen, and because, are providers really purposely not doing that? And, it's most likely implicit bias. I think probably any provider would say, oh, I don't do that. But, looking at the actual facts, they do that. So it's really important to understand implicit bias, maybe, and having peer review and having, people look at your practice and say, we have data here that shows that you're providing this kind of care to one group of people and this kind of care to somebody else, and make, the provider aware of that, so they can change that. Because if you don't, implicit bias is unconscious. You don't know that you're doing something,
Yeah. And as we say here and say other people have this implicit bias, we also have to acknowledge, like, we've all done our own.
Absolutely.
We all, do our jobs and raise our kids or whatever the case may be, with having grown, however many years that we're adults with implicit bias and how to combat it.
Yeah.
Well, it's not just, oh, I'm pointing the finger at you as a doctor, like this is your problem. Well, we've also acknowledged here that we're learning how to do our thing, our lives, live our lives differently as well, knowing what we know too.
Yeah. Yeah.
So there's just a host of things. And this is
right.
what Jay was saying in the beginning, why this is such an overwhelming topic, at least in healthcare. All the topics we've covered it here. Yeah, right. But it does. But I do think from what I'm learning and from what you've described too, is that community health centers are so vital in communities because they're aware of these things. And how do I say this? I don't want to say that people aren't doing this in other places, but their mission is to work through a lot of these things and help people through systems. Like community health workers oftentimes help people navigate systems that they would be unaware of, too overwhelmed to deal with, not have the funding to deal with. So can you talk a little bit about, I think you have.
No, yeah. I mean, that's absolutely true, is that, if you work in a community health center as a provider, you make less money than if you would work at a primary care office at Brigham and Women's or something. And it's the same for nurses and everybody at community health centers. And a lot of the funding is grant funded. A lot of the programs, like that exercise program I was talking about, that was grant funded. I mean, grants are great, but you get them for a limited amount of time. And they also always have strings attached. So there's certain things that you have to do to manage the grant that can take you away from taking care of patients, or might not be exactly what you would want to do, but to get the money, you have to do it this way. And so if you're working with all kinds of different grants, that can make it, difficult to really be able to provide the care that you want. And especially if you know that I have this grant for a year, and then what? How can I continue this program? And the expectation for most grants is, well, you'll be self-sustaining. Well, sometimes you are and sometimes you're not. And also because there's a high, level of people that have mass health for insurance or uninsured or self-pay, on a sliding scale, so that your income is much less than at a fancy primary care office or specialist office. So that makes it difficult as well. And because of that, I worked there. Well, I worked there a lot, but for a long time, but it can be sort of people work there for a few years and, realize they can make more money someplace else and might leave. So sometimes the staff isn't that stable as well. But one other thing I was going to mention that's really important is having providers of, minority providers of color, that look like the patients they're treating. That's really, really important. And Jay, were you the one, you were saying that was like 5% of medical schools are
Yes, it was in 2018. A study showed that it was 5% of MDs were Black, and then only 7% of medical students were Black. So that's it's lower than the representation in our society for sure.
Right, which is 12%. So that's half. So that's a real issue, and and it's not just an issue of, well, people aren't hiring them, it's that they're not there. We hired a new nurse practitioner a couple of years ago, and I tried really hard to get, an NP of color, and the candidates were not out there. The pool, the pool is just not there. And I think that's, true of MDs as well. So that means we have to start way back, when kids are in school. And say, what do you want to be when you grow up? You want to be a nurse practitioner, you want to be a doctor, this is what you need to do. You need to finish school here, and you need to see people in your community that are doing that. and you need to provide support and money and, whatever it takes to get, people through, college and then through their professional program. And, that takes money, that takes support, that takes intention. And I think that's something that's really important.
Yeah. I mean, it takes belief, right? Like we have to believe in our students, all of them.
Right.
It reminds me again of the conversation we had with Joe. We were talking about education, and we also referenced the Black Boys documentary, which I will again recommend to folks if they haven't checked it out yet. It's still available on Peacock, I believe. But just talking, as you said, like we were talking about how students of color weren't becoming teachers, and it was because their representation wasn't there. They're not seeing people of color in those roles as they're growing up, and it's much more difficult for them to aspire to something where they don't see the representation. So yeah, I think it has to start earlier for us, right? So something else so the American Medical Association also earlier in 2020, they had declared that racism was a threat to public health. They came out and made an announcement. They had done a previous one in June where they were saying that they were very committed to some anti-racist work, but then they declared that racism was a threat to public health. And I guess I'm sort of interested because in your take, because we often have this conversation about performative versus practical. And how, we were just talking about trust a few minutes ago, right? And I think from our student body, we've also seen that as well, where they wonder how much of the university's commitment is performative versus a practical commitment, and how can they see those kinds of changes. And the AMA released a strategic plan that included, like making their providers or their registered providers much more aware of issues of implicit bias and things like that. But how do you see that? How do we make sure that these announcements and things like the AMA is saying are not just performative?
Well, I guess, the AMA needs to, I would say, step up and make sure that they have, candidates of color in their medical schools, for example. They need to, provide medical education about implicit bias and racism and how to be anti-racist and microaggressions and all that. They have to, go to, the community and say, what can we do, or what are we doing wrong, or what can we do better in terms of, making, people of color feel comfortable coming to our health centers or, our clinics. And I also think, just working on racial justice in general, whether it's, laws in Congress or at the state level, looking at it through an anti-racist lens and make sure that we're all working on that. I'm thinking the immigrants that I work with in the free medical program, the driver's license issue was a huge issue. People who are undocumented getting driver's license, because people they need their cars to get to work, to support their families, to make it to health appointments, to be healthy, to provide food, so we need to think of health in a large context and how it affects different communities and different groups.
Yeah, thank you.
We have covered so much just history and, describing systems. So you talked a little bit about what the AMA can do and some other things. Any other thoughts about what people can do? All right, so AMA is an enormous organization, and let's be frankly, they are a professional organization. They don't necessarily oversee where a lot of the actual systems have to make changes. They provide guidance and professional development and all kinds of things like that, but they don't have a say over who's being admitted into medical schools, what curriculums are in medical schools, who you're recruiting, those kinds of things. And those are still larger scale things. Ilene, you are you're a good role model for a lot of people, that you're out there, you're working in the community, you're really serving people who need health, regardless of their background, their experience. It doesn't matter to you. You're out there, you're a healthcare provider, and you live to the
truth.
You knew that was coming, right?
Yeah.
You live to your truth. The motto of Framingham State, you live to your truth, of like, I'm just here to help, right? So how can other people who don't necessarily have the background or the knowledge that you have to, you're a nurse practitioner, I'm not, so how could someone like myself, Jay, or just in general, how can people help, make some difference in making the healthcare system or community health, just better community health, things I think that we can chew off a little bit more of that, of how community health and the healthcare system, how can make a difference?
Mm-hmm. Well, I think, the first thing is just becoming knowledgeable, about, health equity, community health, anti-racism, doing a lot of reading about, anti-racism and white supremacy and that kind of thing. I mean, just general knowledge, kind of opens your eyes as to what's going on around you. I think, and I guess I did say the AMA, but I was just thinking, any kind of health center in general needs to step up their game in terms of looking at health inequities and, and racist policies. I mean, that might be, an implicit bias, making sure that all of the people that work there, are knowledgeable and aware of that, and are monitoring their behavior and interactions with each other and with their patients and clients and students. I think that's really important. We had a workshop on racial trauma presented by the Counseling Center to us, and we're wondering what can we, how do we deal with that in the exam room? We have someone come in, how do we recognize it? How do we address it? And, sort of on that micro level, on, person to person level, and also just letting, students know that we're aware of it. We're there for support. We support them here. We're against any kind of anti-racist or any kind of racist activity at all. So I think sort of on a micro level, interaction person to person, but also on a, bigger cultural level. I mean, for one thing, I think we need universal health care in this country. The ACA, did a lot of good, but there were still people that were left, fell through the cracks. To have an insurance system that is based on employment just doesn't make sense. I mean, because it's the people who are unemployed, who have the greatest need for healthcare, for assistance, or health insurance. To really look at the system as a whole and address the issues so that everybody has access to healthcare and doesn't have to worry about switching from job to job or not having a job, or does my insurance cover this provider or that medication? It'd be just so much easier to have, full universal healthcare for everybody. And it should be a right, not a privilege, as it is in this country.
Yeah, there's another huge conversation right there about insurance and health. Right. And you brought up a good point. It's tied to employment, but there's a lot of people who are employed who don't have. Right.
That is true. You're right. All the contract workers. You're right. Yeah.
Or just wait staff who are dependent upon. Yeah. Gig workers, whatever you want to call them. Like there's a large population, and the ACA said, I believe, correct me if I'm wrong, Ilene, but I believe the ACA said that there was you were required to provide insurance to people if you employed a certain number of people. Right. I think it was 11, if I'm incorrect.
I can't quite remember, but also if they worked more than, half time.
Yeah.
Walmart employs lots of part-time people, and their health insurance program is to hand them a Medicaid application.
Right. It's and purposefully, right? We all, and the state does it too. The state contract workers, there's a lot of contractors in the state of Massachusetts, Commonwealth of Massachusetts as well. So it's a whole different conversation. So
right. Yeah.
So I won't go down that rabbit hole right now, maybe for a future podcast, Jay. But Jay, any other questions?
I don't think in terms of questions, but I know that when you and I were planning this episode out, we were wondering, how do we ask this question about what can be done? Because we just think we had it in our minds that healthcare, was just this like other entity that would be so hard to break into. In our previous episodes, we talked about criminal justice, and you see people protesting all the time, or we talk about education. You see people getting into the education field, or they're involved in education themselves somehow. So it's very easy for them to have access to influencing some type of change. And we were wondering, man, how does healthcare, how do you break into that? And I realized that maybe one of the answers as well in terms of what our audience can do is, we hear this old adage of a rising tide like lifts all ships or raises all ships. And it makes me think like, well, yes, maybe we can raise the tide, but we have to choose the body of water that we're going to raise. Because if we can identify some of these other issues that we talk about, many issues of access, right? If there are issues of transportation in your community, if there's something else that you can, if you can support or broadcast the message of some of these community healthcare systems, you can make inroads that way, right? By improving another system somewhere that helps improve access or improve resource allocation to another area, you could influence the way that our healthcare provides its product to people of color.
That is true. Yeah, I agree with that.
Well said, Jay. Very well said. Water, right? It's excellent. So I think, Ilene, you have been phenomenal. Thank you so much for offering your experience, your stories, your knowledge. And your thoughts on going forward too. There's obviously a lot of different opinions on what can be done going forward, but we appreciate you sharing it. And we all know that it's all based on your own experiences and what you see and what you do daily and just how you live your life. And I've worked with you long enough to know that this is how you live your life, and that it's been hard over the past year for all of us to really introspection to see not only how we do our jobs, which is hard enough, but also how we live our lives. And you've shared that a lot today, that how you've changed over the time as well, and really been introspective and how that's affected you as a healthcare provider. So thank you for sharing that as well. That was really important.
Well, thank you for inviting me to have this conversation. I've really enjoyed talking to both of you. I listened to your two other podcasts, and I thought they were excellent. So I feel really honored to be part of the series.
Thank you.
Thank you, Ilene. We're so glad to have you. What an excellent conversation, and one that clearly has a bunch of branches and offshoots that hopefully Ben and I can have with some folks, but hopefully our audience can have as well.
Okay, great. Right. Thank you.
All right.
Thanks, Ilene.
Thanks, everybody.
So much.
All right.
For more information on the topics we discussed in this episode, you can visit these resources. For more information about our support resources here at Framingham State, you can visit these offices.
We'd like to thank Buyer Ads for their technical support, as well as NASPA Region 1 for their generous financial support. And of course, we'd also like to thank the Offices of Community Standards and New Student and Family Programs on the Framingham State campus for making this happen.